Yay.
Hi, everybody. It's Let's Talk Coronavirus Day again.
We're back.
Yay. I'm Rachel Bergstrom. I teach biology and in the Health and Society program at Beloit College. And with me today is...
I'm Ron Watson, your co-host and the co-chair of the Health and Society program, but I also teach in our political science department.
And so we do have a guest who will be joining us in a little bit who had a prior engagement that was going to go until 4 o'clock. Leslie Williams from the anthropology department is going to come and join us to talk today. We're going to talk about data, and there's a lot of data about COVID-19 on the internet. And so we'll spend some time helping you to think through some of the ways that we think through data, questions, caveats, how to interpret some data. But we wanted to start today. It's been a few weeks here. So it's been 2 weeks since we were on last, and a lot has happened. And so I think it's time to check in and see how you're doing. So the things that I've been doing recently are keeping up with my toddler. I've been doing a lot of reading. I have, with the events with George Floyd's murder, I've been doing a lot of reading and examining of my own practices and where I can be a good ally. So most recently, I've been picking up Raising White Kids, which is a book that has given me a lot to think about, the ways in which I parent my child. And one of the most important things that I've learned through reading this and through engagement with other people in our community is that children, it's never too early to start talking about race and racism. Children notice it, and the ways in which we as parents are engaging with race and racism matters. And this is 100% relevant to our discussion of COVID-19 as well, because there's some large fallout that happens with race and racism in healthcare. And access to care. And one of the things that we know deeply and see over and over again in data, again, is that there is a disparity in the communities who are impacted most severely by COVID. In the United States, we see that it's African-American communities, Latinx communities are disproportionately dying as a result of COVID-19. And so it's a good opportunity in the midst of these two clashing crises for us to start thinking very carefully about what we're doing. So I know not everybody who's listening to us is parents, but I think it's an interesting, it's been a really challenging book to read and has been useful for me to be thinking about what my next steps are right now. I've been paying attention to a lot of other women of color, Black women especially. It's important for us as white allies and people who are working towards allyship to pay attention to the words that are coming from the people who are being impacted. And so that's taken a lot of my time recently. Ron, how are you doing?
Yeah, I mean, it's been challenging, right? So, but some folks know, but some may not know that I've been involved ever since, what was that, 2015 when we did when we started Black Lives Matter Beloit, hashtag Black Lives Matter Beloit here. And so these issues obviously very, very personal, very, very impactful in so many ways that are tied to the American experience. And I think I've been, vacillating between feeling like, okay, at least, we're coming together and people are, it feels a little bit different this time, between that sort of deep-seated hope around that, and then the despair around why did yet another person have to be killed by an agent of our state, of the state, for over nothing, right? As I said to some folks before, the reason that unarmed Blacks and others die disproportionately at the hands of police in the United States is because of racism. But the reason anyone dies is because we have a culture of violence that needs to be addressed. And we believe that violence, as a society, we clearly believe that violence solves problems that it does not. And so at any rate, you've already talked a great deal about how these coincide, because I actually would argue probably a good chunk of the energy that's come from this is from the sort of pent up frustration that many people, particularly those communities most impacted by COVID, we start to have this reopening, which is already sort of fraught. And the first thing that happens is the sort of event that is just sort of calculated to just burn people to their core. And in that sense, it's been a troubling week. But we have to continue to deal with this public health crisis that is not going away. And that's what we'll sort of talk about as well. But at the same time, recognizing that there's another public health crisis that isn't going away as well. And that is the crisis caused by racism that's sort of deeply embedded in the American psyche and the American project. So at any rate, we'll talk about numbers today, but this is a topic we will most certainly continue to revisit.
Right, and I think it's we welcome questions and comments in the Facebook comments section. We do monitor that while we're going through our discussion, and we welcome your questions as we talk. So we just had our guest show up, Leslie. Leslie Williams is from the Department of Anthropology. Leslie, Ron and I were just checking in on what's been a pretty heavy week. And so we want to give you an opportunity to do the same. Introduce yourself and tell us what you've been thinking about this week.
Sure. So my name is Leslie Williams. I'm a biological anthropologist who specializes in archaeology, which means I study bones. In particular, I study the effects of disasters, whether that's long-term climate change or plagues or disease on the health of human populations. Most of my work is done in medieval Germany. And so I go to Munich and I look at bones and I see what they can tell us about what past health was like. So that's my general research. Of course, I think the past week has been incredibly overwhelming, not just on the pandemic standpoint, but of course an incredibly powerful week to see so many people protesting and making their voices heard. And as a scientist and as an anthropologist, it is just so important to me to sort of reaffirm the idea that while race does not have a biological, does not have support biologically, it is an incredibly meaningful social category, and the effects of systemic racism and oppression over the last 400 years continue to be enacted today. And we cannot consider people's health without considering crucial social conditions like race, like systemic racism and oppression. So, sorry, not very eloquent, but
hey, it's a lot to deal with, and this is one of those places where those of us who have spent our academic lives and then our actual other lives dealing with it, it's hard for us to articulate it sometimes too, right? And so
Sure.
This is the reality is that we all are finding ourselves having to explain the world that we see and have that sort of be such incongruent with the world that we want and that we want to be in. But at the same time, hopefully this will bring us together as we start to find the language necessary to talk about it and actually do something about it. More importantly, because our generation has to be the generation where this largely ends.
Right.
I mean, it has to be. I can't let my kids or my grandkids go through this crap. So
No.
there we all are.
No.
So
Well, and I think that, Leslie, I think that there's an important thing that you stated there. It's that scientists should and do care about these issues as well. And even though there is no biological basis, really there are outcomes that matter. And we know that it matters for COVID-19.
Absolutely.
So there are a lot of things that we should be paying attention to around the protests and around the current social movements that are related to COVID-19. And one of the issues that I've heard about a lot on the news has been concerns about the getting people all together. Incredibly important for people to be together right now, and incredibly challenging to think about that from a public health standpoint. And so I think that this is a somewhat clunky transition to starting to look at data, but it gives us something to start thinking about as we think about what is the data that we have, and what is the data how can we use data to understand what's happening with COVID-19. And so what I've done is I've compiled a set of dashboards, some figures from papers, and some epidemiological information for us to talk through together, much as I would do in one of my classes. And Ron and Leslie both teach statistics classes at the Beloit College, and they're experts to talk about. And I spend a lot of time thinking about data and how do students understand data in emerging diseases. And so I'm going to screen share here, folks. And
So
what I'm
exciting.
screen sharing, I'm also going to put into the comments. I'll put the link into the comments on Facebook so that you can also access it and play around with it, because a lot of these sources of data are really interesting. And so Ron and Leslie, as we start in on these, feel free to direct me to click on things and to instruct me to what you want to look at. So without further ado, we're going to start with one of the original dashboards. And I apologize, my map always takes a minute or two to catch up. And so here we've got the dashboard, and in the middle here, this is the Johns Hopkins dashboard. The link is now in the comments. There's a number of different pieces of information, but up in the corner here, we've got the total confirmed cases, 6,500,000, almost 6.5 million cases. On the side here, we've got confirmed cases by country, region, and sovereignty. So this is just a little bit more broken down. So the cool thing about a dashboard like this is we can click on it, and it will change the presentation on the screen so that now our data is primarily looking at just the United States. We can zoom in a little bit and look at the map. So if sorry, my internet takes a second sometimes, but if we zoom all the way in on the United States here, what we can see is a bunch of red dots. And so Leslie and Ron, what are the red dots?
So the red dots are confirmed cases. In the United States, as opposed to many other parts of the world, they are going by county now. So it's just as a nice contrast, you can look up at Canada. The Canadian numbers are clearly by province. Numbers used to be by state, and now they are down at the county level. Which, given, of course, the distribution of population across the United States, gives you a little bit of a sense about the distribution of COVID, but it's obscured by the fact that we've got these major metropolitan centers where we have basically dot overlaying dot overlaying dot overlaying dot. right? So it gives us a bit of a sense, but because our population is not distributed equally across the geography of the US, it also is going to give us a little bit of a skewed sense about where current outbreaks might be.
So Ron, when you look at a map like this, what are the things that you pay attention to in the public health perspective or as a political scientist?
Oh, I mean, as a political scientist, the first thing that pops into my mind is policy, right? And I look and I wonder, this rightly or wrongly, what sort of policies were in place that, for example, enabled one area of the country to experience fewer cases than another, right? And that's sort of the thing that immediately pops to mind. Or put differently, if I look at the map and you look down at some of, like you look at New York all the way down the eastern seaboard, right? I look at how intense how intensely red that is, and I think, okay, so what is it about that area, right? Without seeing anything else, right? What is it about that makes sense? And of course, that's following all the way down the coast, right? All of these cities that are effectively coastal cities, right? Which in some respects tells me something, or at least potentially tells us something about how the disease may have been transmitted, right? Yeah, I see a few different things like that. Of course, the thing that's most important for me now, especially given the reopening, is where are we seeing cases start to like pop up or clusters start to spike? And I'm not familiar enough with this particular dashboard to see that, but what I do know is we were close to that 100,000 milestone. The sort of grim milestone as it goes, and we are clearly over that now, right?
We are well over that.
Yeah,
so.
I think a lot of folks are thinking that because the country is reopening, that means that, oh, it's okay. And I've had to go out I'm the designated shopper in the house, right? I go out and I see there are lots of people like not even wearing masks, no attempts to socially distance. And that's simply not the case, right? I mean, the places that reopened first have seen, I think most of them, a couple have seen a spike in cases. So yeah, I mean, I'm looking at this thinking, how are these colors, how is that red going to shift here soon, right?
Right. Yeah. Well, and when I think about this map, I think from an epidemiological perspective, the things that epidemiologists are interested in knowing are person, place, and time. And so when I talk with my students in emerging diseases about epidemiology, those are the three things: person, who's being infected, like what type of people, what are the characteristics of the people, who are they, who are they? We got to know something about them. The place where it's located. And so that's what this map gives us in a really nice format. I think that's easy to digest because we see the red and it's easy to interpret. And then the time, we don't necessarily see the time here, but that's actually something that I find really interesting. Over in the bottom corner here of the dashboard, we have this type of graph that we've got up here. It's called daily cases here in the bottom, but it's actually a technical term is an epidemiological curve. And this is the new cases that are reported on a daily basis. And so this now gives us some information about person, number of people, and time. And I think that one of the things that's fascinating to me about this curve is you can see that there are these, and if you mouse over it let me back up for a second. When we talk about graphs, we should orient everybody to what's going on in the graph, right? Yeah. I see both Ron and Leslie are like, yes, Rachel, you should. Over here on the y-axis, we have the number of people. And this is 5,000, 10,000, 15,000. So we're going by 5,000s. And on the bottom here, we've got time, and this is dates. And one of the cool things about this graph is the way that it's set up. You can actually mouse over each of the bars and see what the date was and how many new cases there were. And so this is the number of cases that have been positive, okay, on that particular day. And what we see on this is that there's this kind of sawtooth pattern. And if you see, there's a sawtooth pattern that there's, so 4/9, April 9th, and then we've got another mini peak on the 17th, about 8 days apart, and about another 8 days apart on the 24th, 7 or 8 days apart on the 24th, we see another peak. Epidemiologists use this kind of information, this kind of sawtooth path, to understand what type of an outbreak this is. And so in this case, it would be more of a pattern of what's called a propagated outbreak, where it's transmitted, it's a disease transmitted from person to person to person. And so there's some really interesting data in there, but I'm actually interested in discussing this graph with both of you from the standpoint of what's it lacking? What are you concerned about as somebody who thinks about data when you see a graph like this? That's supposed to represent the outbreak in the United States.
Well, this is the world, I think.
This is actually only the United States.
It is only the United States. Okay.
It's only U.S. I actually thought it was the world. I thought we were over on the world.
Oh, so I that's actually a good question, because so when I switched over here to the United States, the whole dashboard switches. But okay, we can switch back to. Maybe we can switch back. I don't know if we can. Okay. Well, regardless of where it is, large population.
Yeah, it's clearly the United States because of the number, right? So it's fine.
Yeah,
no problem.
Yeah.
So I'm hoping that'll open up again. So what do you think about when you look at data that's collected on people?
I mean, I go back to this idea of the importance of thinking about the geography, right? Because, and especially with something like COVID, which is being transmitted person to person, the outbreaks are always going to be so very regionalized, right? For a while until they start spreading. And so what we miss in a map like this is how heavily, for example, how heavily impacted New York was, especially early on, right? And then what we also miss then is how many new cases are coming in new regions, right? So I know I was complaining about the previous map, mostly because the previous map didn't give us a sense of time. Now we've got a sense of time, but we don't have the sense of space. So, I mean, again, just to go back to what you were talking about, Rachel, sort of person, place, and time ends up being crucial to understand what we're looking at here. It also, I think, is really important when we think about how generally people are viewing the pandemic, right? So we see these massive increases in new cases early on, but if they're happening in one region, I think certainly what we hear from people across the country is that they don't feel personally affected by it, right? Because it's happening in New York, or it's happening in Chicago, or it's happening in Seattle or San Francisco or what have you. And it is only when it really starts spreading outwards that people begin to understand it. I mean, from what I can, from sort of what I've observed in the last 2 months, what you see is people who sort of have this terminology of like fighting this invisible war, right? And I think it's really hard for people to continue to fight an invisible war when they don't ever, not even see it, but don't even see the effects of it, right?
Yeah.
So I think that that's one of the big challenges that epidemiologists and public health officials are facing in attempting to enact these upstream interventions that we know work. And that, I mean, if you look at the downward trajectory in general of these new cases, that's sort of positive looking, right? Yeah. Yes, it is moving slightly downwards as we go. Probably, I mean, I'm supposing, I suppose that is due to the all of the stay-at-home orders across the country. This had some effect on that. But the challenge is that an epidemiologist and a public health official has to face is people not seeing it affect people that are close to them. And therefore sort of being unwilling to make those continued personal sacrifices.
Right.
Yeah.
I do want to throw it to Ron though with that, because he, as the policy expert, probably could say a lot more than I could.
Oh, no, not at all. I mean, I think that's exactly, I mean, when I see the downward trend, I would be super interested in saying, okay, when did we see the jump in stay-at-home orders? Right? That would be, I think, where I would sort of.
They try to salsa that shit off. And they're like, no,
I think we got some other info coming in.
Yeah.
But I think that's where I would really sort of focus, right? What I think also is I would love to see. You've already talked about region. I think that's key. But what I really want to see too is some demographic. I would love to see demographic breakdowns of this, right?
Yep.
When COVID first emerged, there was this conversation about males of a particular age being especially susceptible, right? And then, of course, once it starts to take off in the United States, we see that African American and Latinx individuals seem to be sort of disproportionately affected. And so that's what I would also like to see, right? I would love to have this map and then say, okay, now that's overlay region. Let's overlay gender or sex rather, and then let's overlay race and ethnicity, right? I think that would be sort of important information as well. Of course, you can't do this all in the same graph, but I would like to see graphs that are doing that as well.
Yeah, I think that's actually a really good question. I mean, how do we effectively show this data, right? And so I'd like to actually switch to a different presentation of the data with a few things to keep in mind. So first of all, I want to point out this number up here, this 1,841,629. And then if we switch to another map, now this is the CDC. The CDC is presenting its data a little bit differently. And we see that we've got 106,202 deaths, 106,696 deaths. So we've got a difference in the numbers here too. And I think that can be confusing to people. It makes me think about the challenge of collecting this information, the challenge of knowing who's actually infected, the challenge of testing. We've heard so much about the importance of testing, and we've heard so much about how we are not hitting the mark for that. And so knowing exactly what this total cases number is a really interesting thing to think about. Actually, this brings me back to something that I think we should look at on this map here. In China, way back in, how long ago was that? How long has that pandemic been going on? Oh, Ron, you're muted.
20 years? 20 years it feels like.
Yeah, at least since what, December and January is when everything sort of hit the fan, right?
Yeah. Well, and so I want to show this map, or this is now the epidemiological curve of China, starting back in January, it looks like. And I want to point out this day here. This day, February 13th, 15,000 cases. And thinking about what this means, was that 15,000 cases, 15,000 people showed up all of a sudden infected? No. If we look at the trend, it's a really interesting kind of outlier here. And what this comes down to is the idea of a case definition, which is what is the actual disease? And this was a shift in the case definition. So it was no longer just people who were 100% confirmed to have it, but also people who had other characteristics as well. And so when we look at this number on the CDC map, what are you thinking about, Ron, in terms of what, from the standpoint of collecting this data, what do you think about these numbers? What are you concerned about? What are you interested in knowing about this number versus the actual spread of the disease?
Yeah, I mean, when I see this, what it makes me, and especially the discrepancy between the two different charts, right? I think that what that suggests to me, I mean, obviously is exactly as you said, is something about testing. But I think part of it too is well, it's still tied to testing, is the U.S. had such a difficult time getting testing out to folks, right? And I don't know if any of you have, either of you even tried to get tested during this period, but I did try to, and despite the sort of information that was saying, oh yeah, the tests are available, that I did not find that to be the case. So anyone who wants them, that is definitely not true, right?
Yeah,
But
yeah.
the other issue around the cases was that that there were several different tests being used, and that also makes me think that that's part of that discrepancy that we see. But there were several different tests, and at least one of those tests was giving false negatives, right? Which is kind of the worst situation, right? Is giving false. I mean, if you get false positive, worst case scenario, okay, go isolate at home and it's okay, right? It turns out that it's just allergies. But then you get a false negative, that's bad. And so, I mean, part of when I see something like this, it does make me question. But not, I don't want to say like super question, because we're not talking about a gigantic discrepancy here, right? But it does make me question a little bit about what sort of reporting agencies were involved, what sort of reporting guidelines were involved. I mean, this is the United States with 50 different states that potentially have, but generally speaking don't, but potentially have multiple different ways. I won't say 50 different ways, but multiple different ways to go about either accessing tests or assessing who is sick. Yeah, I mean, and if the CDC decided to sort of hold on to a particular approach in a way that was different from Johns Hopkins, then I think that's how we could see that discrepancy. That's how I would think about it. And then the bigger question would be, well, which one should you trust, right? I would say I trust both, because there's no a priori reason to think that they either of those is false, right, per se. But if I were then going to take this data, I might bring them together and sort of split the difference some way using some statistical techniques, right?
Yeah, I think that's a great question, Ron. Like, what data do you trust, and why do you trust it? And it's okay to trust different data sources.
Sure. As long as they are baseline reliable.
Yes.
That's the key thing, right?
Yeah. And so when I talk with my students about what data can you trust about epidemics, the CDC is one of the places that we start. One of the challenges, though, I think, aside from just testing, is we talked a little bit about it in our last meeting, or our last show about masks. One of the challenges is so many people are asymptomatic, right? And so we're not actually seeing, this is probably still an underestimate of the number of people who have been infected by the, oh, you've got your mask.
I got a new one. This came directly from California from a friend of ours named Theron Seitz, who is a nurse out there in California. But yeah, he made these and sent them to us.
Beautiful.
I just wanted to give a little... Thank you, Theron. Aren't these beautiful? Anyway, sorry.
That is gorgeous.
Yeah, go ahead.
Well, but it is a problem, right? That there's first of all the access, or the availability of testing to begin with. Second of all, access to testing. Third of all, not everybody who's sick is going to be tested, because humans. And last, we don't actually know, we aren't going to capture everybody in every single epidemiological survey that's infected. And so I think you're right, the statistics become really important to know a little bit more about our population. So I hate to push us along, but I want to make sure we've looked at two dashboards. There's a third dashboard that I think is really interesting, that I want us to talk about, and that is out of, I believe this one's out of the University of Washington. But this one has predictions and forecasts.
A lot of the models are coming out of IHME.
Yeah, and so that's this one. And so I wanted to talk about this one because of the predictions and the models, and thinking about, as people who are well versed in statistics, how do you approach looking at a model? So back to our dashboard here. This is a different type of dashboard. again, looking on the side here, we're looking at total deaths in this particular graph, total deaths on the y-axis, date on the x-axis. How do you interpret this? How do you think through this, Ron and Leslie?
Well, there's a couple of important things to think about here. One, of course, is the fact that that shaded area represents an error range. And notice that as the further away we get in time, the greater that error range becomes.
That's right. Yeah.
That's because there are so many possible variables that are going to intersect with any model about what's going to happen epidemiologically, that means that we're not going to know as much the further out we get. We can't predict as much what's going to happen. So we get a general sense about what we might be seeing, but we're not entirely certain, because a model is only as good as the information, the data that we put into creating it. The people at University of Washington are doing an amazing job with these models. They're managing data sets that are highly complex, and attempting to model the behavior of people is, I don't know, the herding cats thing sort of comes to mind, you know, that people, we are not always, in fact, we are frequently not rational actors in different circumstances. So that's sort of like my first thing, is that the model is going to be as good as the information that's placed into it, but it's working always against the complexity of trying to measure human behavior, the behavior of the virus, environmental behavior on top of it. So, I mean, you're trying to measure something incredibly difficult.
Yeah, I mean, I obviously completely agree. And I think that part of what may be fueling some of the doubt, right, around COVID and the seriousness of this disease has been the focus early on projections, right, which is the only thing you have to work on, right? I mean, if you notice that there's a spike in some very serious cases, particularly a fatal illness, it only makes sense then to make some projections. And of course, some of the early projections we're talking about, deaths upwards of 2 million, right? But what people forget is that was given under certain conditions, right? The condition is that if we do nothing, right? If we just keep, if we don't shut things down, if we do nothing, then we're talking about that, right? And but even at the same time, I will say, even to sort of err on the side of the naysayers a little bit, is that what Leslie said is absolutely correct, right? I mean, a lot of that can't take into account how people are going to behave, how any specific pocket of individuals will respond. I mean, you could have every kind of response, at least in theory, every kind of response from one person gets ill out of a group of 50 to all of them get ill, right? And if you split the difference, you say, well, half of them get ill. That's not unreasonable, especially if you're dealing with a fatal illness, right? So when it comes down to it, we want to always err on the conservative side, right? And the conservative side in an epidemic doesn't mean like small number of cases. You err on the side of what is the worst case scenario. That's the conservative approach, right? And so, yeah, in that sense, you see something like this, and you have to take it with a grain of salt, but you take it with a grain of salt, recognizing that the information, the projection is only as good, as you rightly said, as the information that it's based on.
Yeah, I think
one of the things that I've just to put a little plug in for historical epidemiology here, one of the things that is kind of beneficial is that we have a model that we can look at that shows us a little bit about how people respond, and shows us a little bit about how a virus without a vaccine moves through communities. And that, of course, is the 1918 pandemic. Right. So we can see exactly what happened then, and because it's happened in 1918, our records are pretty good about it. So we know in general which populations were vulnerable, what happened in certain cities, and in particular, what happens in cities where stricter social distancing measures were enacted compared to those with more lenient social distancing measures. So having that information does help as well. Obviously, there are many differences between 1918 and today, right? And we're talking about a different virus than influenza, but it does give us something to work with in addition to a mathematical model that's looking at epidemiological data. And that thing that we are able to look at in some ways does account for some of those complexities of human behavior because we can see what people did.
Yeah. Yep. No, I think that that's really good. It's not, we are flying pretty blind, but not completely blind here.
Right. Like with maybe one eye closed and one eye sort of half closed, right?
Yes. And a little bit of a mask accidentally up over our eyes instead of our mouth and nose. So I want to make a plug for this particular website because it is so interesting and full of data. We just looked at one graph on here. You can do some comparisons. If you're interested in seeing data visualizations and playing around with it and, clicking on things and seeing how things change over time, this is the site for you because
can I make a quick interruption there, Rachel,
yes.
before you move on? I want to just make a note about one of these really important metrics that gets lost. And that is what's on the x-axis right now, or the y-axis right now. And that's total deaths per 100,000. One of the things we miss in a pandemic when it comes to vulnerability and risk is the sense of how many people are there to be affected by something.
Right.
So
Yes.
it's going to see more cases in large communities because there are more people who could be affected there. So it doesn't tell us about relative risk unless we are measuring on a basis of how large our vulnerable population is. Okay, sorry, please continue.
No, it's a great point. And I think that it's worthwhile to think about as you're looking at data, what is the data actually showing? Knowing what's on the X and Y axis matters and what those mean matter. So there's a whole bunch of dashboards out there. I found a gazillion of them in looking. This one's from Splunk. There's also, so this is, we're seeing a lot of the same things in these dashboards. It's really interesting to go through and compare them to one another and to think about why they're seeing differences. But I wanted to end today on a visualization from the New York Times. And thinking about, so we've been looking at some pretty standard like X and Y graphs. This is not that. This is from the Upshot, and I'll put this in the comments as well. It's from the Upshot, which is the New York Times health side of things. And they're looking at herd immunity and this idea that we can protect one another from the disease by having enough people who are immune. And I picked this one because this is a completely different way of looking at the data. We could do this on an X and Y axis. As humans, what do you think of this data, Ron?
Yeah, I mean, it reminds me of the early conversations that both the US president and of course the British Prime Minister had, right? About, well, let's just let it, we'll do herd immunity. Okay. But this is what would be necessary, right? This herd immunity estimate.
60%.
60%. I mean, that's how you can have people who refuse vaccines still not get ill, right? And it's sort of extraordinary when you look at this, right? Because New York City, obviously in the United States, the most impacted community, still less than 20% of folks have antibodies. And of course, this is, we are starting, sorry about that. We're starting to understand, or at least we're still trying to determine whether having antibodies means that you're actually immune, right? We have, at this point, I think the last time I checked, it was like 6 different strains that were noticed of COVID-19, of the pathogen that leads to COVID-19. But even at that, we still don't know. But we don't even have even that sort of basic, even sort of what you might say, even sort of basic thought about being herd immune yet in place. So yeah, it's not encouraging. It's not encouraging at all.
We got ways to go.
Long ways to go. And
Yeah.
that's a lot of, so what that translates into is that's a lot of sick people that have to happen first.
Yeah.
Right.
And a lot of deaths that would get
that's
to
right.
that point.
That's right.
So to take this sort of on a policy standpoint, to go towards this perception of how to treat or how to manage the pandemic, I mean, it requires a massive actual sacrifice in lives.
That's right.
So and of course too, our concepts of herd immunity are really important. But again, this is a new, it's a new pathogen. It's behaving in many ways, in ways we don't entirely understand.
That's right.
In terms of who is infecting more people at which point, the massive numbers of people who appear to be asymptomatic, our lack of knowledge about antibody testing and whether or not that people are going to get a sustained immunity from it. We can't look at something like measles and say, oh yes, okay, clearly we must do exactly what we do for measles.
That's right. That's exactly right.
Which what we do and should do for measles is vaccinate.
We know how to take care of measles. We do, and the key is vaccination, people.
Exactly. Now, in talking about the data that we're looking at here, I mean, I think it is very powerful to demonstrate the idea of herd immunity with sort of these dots on a graph, right? Dots in a circle. Says more, tells us more than a bar chart would about particular concepts, right? Because again, I'm going to go back to Rachel's comments with epidemiology, right? It is a matter of people and place and time. And so what this gives us is people and place, the sense of distance and association between people. What I think is cool is how it helps illustrate the idea of herd immunity though too, with that idea of 60% of the population. You can see how that works when you look at a graph like this.
That's right.
And it becomes clear that it's just, we have a long way to go with a lot of risks involved if we wanted to get to that chart.
But I think that we're at a point where we're really inundated with data, and being able to see it in multiple different formats is really helpful. But there are, of course, things that we need to think about in terms of what data do we trust? How do we know that it's trustworthy? Where does it come from? Usually when there's data that has, like on this one, it says that it's from the sources from New York State, Public Health England, other places, we can trace it back to we can trace its provenance. Where did it come from? Who collected it? That helps to lend it some credibility. Very interesting data out there on the pandemic, and we've only shown you a few things and talked through a few very, very small examples of the types of data that you can get your hands on right now. But if you're interested in this kind of thing, reach out to us via Facebook, because we can give you some other resources to look at as well. And so we've come to the end of our time here. Thank you so much, Leslie, for joining us today. It was absolutely delightful to hear how you think through data. So we like to end with a little, what are you planning on doing to next? So Ron, what are you looking forward to? What are you thinking about for this coming week?
Yeah, I mean, as you all know, we have many summer projects, of course. I'm looking forward this week to wrapping up my men's health course and preparing for some other stuff. I'm going to work with students in Upward Bound, so preparing for that as well, and as well as some other work around Black Lives Matter Beloit. So got that on.
Yeah. And Leslie, what are you looking forward to for this next week?
Well, I'm teaching a Beloit mod this summer, and we're moving into talking about inheritance, and pretty soon we're going to be talking about human adaptation, variation, and race, as well as thinking about disease, and with in particular COVID and the pandemic as a case study. So I'm excited about preparing all of that, and with working with some research students for the PAHULA biomedical fellowship this summer, and we're
Yay!
looking at oral health, dental disease in past populations in Germany. So kind of exciting stuff on the front, and maybe eventually actually turning my sourdough starter into actual sourdough bread. It's a big step.
That's excellent. Well, and I'm actually looking forward to, we're turning Let's Talk Coronavirus into a class. So yay! So if you are an incoming student who's starting Beloit College in the fall and you'd like credit for showing up here, we'd love to have you join the class. If you have questions about that, you can contact your AMP advisor or contact admissions. They can connect you with that. So Ron and I will be back in July and August every week. 7 weeks in July and August. With exciting colleagues to talk about how the pandemic is more than just a disease. So we're really excited about that. And with that, thank you again, everybody, for joining us. Keep in touch, stay safe, and do your work.
Take care, everyone.
All right.